Welcome to CARDIA, Hearts and Sciences, the program dedicated to the understanding of the human heart. We're looking at computed tomography here and how CT scans help cardiologists and their patients understand what's going on inside.
Yeah.
And Casey Anger, I'm here at this calcium scanner. It's actually a CT scanner, right?
Yep.
This is a big, fast CT scanner.
Correct.
And this is a kind of a basic screening for calcium for people who wonder if they might not have some plaque developing in their arteries. Is that right?
That's very correct. It's about a 5-minute study. We hook you up. We'll take some pictures of your heart, see if there's any buildup in it, see if there's any calcium that the doctors can see that may not necessarily be causing problems right now, but could cause it in the future. So they actually get a heads up on what's going on with your cardiac.
Yeah. So this is kind of a starting point for people, isn't it?
Just as a baseline.
Yeah. And then if the doctor finds out that I have a serious amount of buildup in my arteries, then they would intervene in some way.
Yep.
They would take me to the cath lab.
Kick-start a new process.
Yeah, okay, got you.
Yeah.
So I keep hearing about how quick and easy this process is, and it takes only a matter of a couple of minutes.
Yeah.
Is that true?
Yeah, it's about 4 or 5 minutes, a little bit longer if we add in the hooking up the machine.
Yeah.
Maybe 7 minutes total, beginning to end.
Want to get me started?
Yeah, we'll get you going
Okay.
here. I'm going to have you just have a seat right here for me.
Okay.
Yeah, we'll have you go ahead and lay on down here, and we'll get you hooked up to everything.
Okay.
So I'll have you take that mic out of your pocket here.
Okay.
All right, I'm going to have you take your 3 buttons down on your shirt and open your shirt up for me. I'm going to raise you up while you're doing that.
Okay. Just 3 is enough?
Just the top 3 buttons, yeah. And I'm going to hook 4 patches up to your chest. They're a little bit sticky, which will be fun when we're done. I'm going to have you raise your head up for me just a bit. There you go. I'm going to come around to the other side. Same thing as the other side.
Was it just 2 on each side?
2 on each side.
Uh-huh.
And these monitor your heart rate for us and your rhythm so we can get a good, constant, steady scan on you. All right, so I'm going to bring you into the scanner a little bit here. I want you to bring your arms up over your head for me.
Like so?
That's perfect.
Okay.
And we'll get you set up for these pictures.
These take real fast pictures, don't they?
Yeah. We'll have you done once I get you lined up here in about 3 minutes. Beginning to end now. The machine will tell you to take a breath in and hold it and tell you when to breathe again, and it'll ask you to do that about 3 times, okay?
Okay.
So just hold real still for me and we'll be done here shortly.
Stop breathing.
All right, you can go ahead and bring your arms down. We're all done.
All right.
Gonna bring you out of there and
That was like nothing.
No, it's quick.
I mean, there's no pain, no. I've had an MRI and there's all that banging around. There's no sound of any kind. It's just pretty easy.
3 breath holds and you're done. All right, I'm gonna unhook these leads here.
Okay.
I'm gonna take those patches off of you. My hands are cold, I'm sorry.
No, it's fine. It's just a matter of like a few days, and the doctor tells me what he's found.
It is just a few days, and they'll send a report to you, and you get a phone call, and they go from there.
At the end of this program, we're going to have the results of the scan. Thank you, Casey.
No problem.
Appreciate it.
No problem. Have a good day.
In addition to a relatively simple calcium scan, cardiologists and radiologists have been collaborating for decades with CT technology, as Dr. Zada and Dr. Mishkel are doing here today.
Well, I'm in the bowels of St. John's Hospital, the radiology department with Dr. Vince Zada, and Vince is a special type of radiologist, a cardiac radiologist. So Vince, tell us briefly, what is a cardiac radiologist? How is it different from another type of radiologist?
So all radiologists go through basic 5-year residency after med school, and then we could choose which subspecialty we do. And what I did an extra year of training reading only cardiac images to get in-depth training and to learn the nuances, catch up on the papers, and learn the techniques and protocols of cardiac radiology.
And you and I and the rest of the cardiologists have been working increasingly closer and closer together, doing x-rays of aneurysms, x-rays of hearts, and now we're offering coronary angiography done with CT scanning. But the first thing that we began to offer was calcium scoring, and maybe you can take us through a patient and a calcium score and how you do it and what we see when we get a calcium score.
Okay, so we do this gated study on a non-contrast. We use the lowest radiation dose possible, and we acquire these diagnostic images that get the layout of the land, where you see exquisite detail of all the coronary arteries, the LAD, the left main, the circumflex, and the right coronary. And what we get to do is get a brief picture overview of how much calcium is involving the coronaries, and not only the amount of calcium, which coronary arteries it involves.
So let me just interrupt you briefly. So the first thing I want to touch on is you said no contrast. So that means essentially no dye.
No intravenous contrast, no stick, no IV. You just show up.
Literally lie down and 5 minutes later we have a CT scan.
Exactly.
And then the second thing you mentioned was low radiation. So put this type of screening test, because this is a screening test for coronary artery disease, put that type of radiation dosing, say in layman's terms, in terms of say a chest x-ray or just going out into the sunlight.
Gotcha. So a typical chest CT, which this is actually, is usually about 3 millisieverts. And as we get a calcium score, it can be anywhere in the range of 0.8 to 1.1 millisieverts dose of radiation exposure. What that means usually, this particular scan was scanned at 0.7 because we have specific technology here at St. John's and advanced CT hardware that takes the latest and greatest technology to reduce the radiation as low as possible, one of the lowest in the nation. What those numbers typically mean for a calcium score is that it's the same amount of radiation that if you lived in Colorado for a year, or if you did 3 transatlantic flights, possibly, just to put
Yes,
it in layman's
I think people are shocked to learn that when you go across the ocean in a plane, or if you're living at altitude, you're getting radiation, ambient
Yes.
radiation.
Yes.
So now calcium scoring is a technique to look at really essentially what laymen think of as hardening of the arteries, right?
Correct.
And the assumption is that the more hardening of the arteries you have, that's a marker for plaque buildup inside the arteries.
Correct. It is kind of like the first intro inside the coronary arteries as to what's going on behind the skin, in the skin, on top of the traditional markers of cholesterol, blood pressure. It's another risk predictor. Of course, we all know of some of the limitations. There are things of non-calcified plaques that we occasionally miss, or the calcium score do not see. But it's with the low amount of radiation, no invasiveness. It's one of the best things we have available to assess risk.
I agree with you. If you have a calcium score of 0, that's probably the best predictor of no cardiac events over the next 5 years. And if you have a calcium score of, say, over 400, that's a pretty good predictor of events. So what does this patient have?
So basically, as you can see on the image-wise, we follow the left main here. That looks pretty clean. But as you go to the LAD, which supplies the majority of the heart, we get extensive calcifications involving the diagonals and the mid and distal segments. And then pretty much using software, we circle the amount of calcium. It tells us the volume and the density, and it gives us what's called a Gadsden score. As you can see here on the right, we can zoom in here. It quantifies the score here. You can see the left main, as we can see objectively on here, obviously no calcium, you get a score of 0. However, the healthy calcification burden, the density and the amount is high.
So anything that's bright white
Yeah.
is calcium, and anything that's kind of this grayish soft color is just the artery or soft tissues.
Couldn't have said it better myself.
Okay.
Yeah, so exactly. That bright white stuff here, that's the calcium, that's the dense calcium. And you can see that the score is 463, the left circumflex is 198, and on the right, you can see that the bright white areas are a very small amount, not as a lot in the LAD. So
Not as
therefore,
dense.
Not as dense. So it's a lesser score of 45, and you get a total score of 706. Therefore, as you said, with any score greater than 400, that's a high risk predictor for a future cardiac event.
And then we also have to take into context their age, right?
Correct. So basically, on the next page of the graph, and every patient gets a copy of this report, what they will see here on the next screen is curves related to the amount of calcium on here on the y-axis going from 1 to 10,000. And then as you can see here on the bottom, the age ranges. And based on a certain populations, we have calculated the amount of calcium that is normalized to that age, and also the sex of the patient, whether they're female or male. And as you can see in this particular person, it's an asymptomatic men. So as here, the star marks the area of the calcium score and the age, and based on this is able to predict the percentage they are in relation to the population.
So we can give this report to a patient who's interested in knowing what their coronary risk is, and then they can then go over it with a cardiologist and then determine it based on this, because it's just a number. It doesn't mean anything
Yeah.
other than a number, and you have to
Exactly.
take it within the clinical context. What's the
course.
next step in terms of CT technology? This is without contrast. What about if we wanted to learn about how tight this narrowing might be? Is there a technology that we can use now?
Yeah, there's multiple technology, and it's up to, like, if the radiologist is kind of like the guy that watches the films and creates the plan, and the cardiologist and the cardiothoracic surgeon are like the quarterback trying to find the final play. We just offer a couple solutions. So you always got stress test and echo, as you already know, but we also have coronary CT angiogram on top of conventional angiography. But coronary CT angiogram is definitely a non-invasive way to evaluate the tightness of the stenosis. That may be an option if the cardiologists think that's the best next step.
So are you able to pull up a CT coronary angiogram and show us that?
Yeah, let us do that. Okay.
So this would be a way of quantifying, taking pictures of the arteries to your heart without actually having to do a heart catheterization, right?
Correct. So similar technology to the calcium score. The only difference is that we give IV contrast this time.
Okay.
Okay, so let me put up the raw images here, and I'll grab a couple of the reconstructions that we made,
Okay. Oh,
and then pull this here, and then we'll look at all the key vessels first. So as you can see on the first screen here, almost looks like the calcium score, but the only difference, you see bright stuff in
Right.
the vessels. That's the iodinated intravenous contrast that we inject through a vein access. From that way, not only can we tell areas of calcification on the parts that were non-calcified, we could see how big the lumen is and how
Right.
tight the stenosis. So obviously this is a rough value. So what we do is we put it in a third-party processor, and we're able to draw a center line through all the coronary arteries. In this case, this is the right coronary artery. And what we do is create multiplanar reformats and be able to assess the tightness of stenosis along the whole tract.
so this is a patient of mine, and this is his right coronary artery, correct?
Correct.
I can still do it, okay?
Yeah.
And what do you see in that picture there?
Okay, so as you can see in the proximal portion, it's pretty clean, you know, and we knew that from the, like if you did a calcium score, you could see it. But on the parts that have non-calcifications, you know, you can see in this part there's a non-calcified plaque here that we wouldn't have seen on the calcium score.
Right.
But unfortunately for this patient, it's I would characterize as a less than 30% mild stenosis. However, in this part, in the mid portion of the right coronary, you could see that the calcification, this dense calcification here, this gray stuff right here, that's the blood. You can see that there's a very nice string sign, very stenotic lumen there. However, with calcium blooming artifact, it may overcall the tightness of the stenosis, you know, and that's where the next technology comes in.
And what technology is that?
That's FFRCT. So basically, in previous days, what coronary CTA and calcium score, it offers explanations of the anatomy.
Right.
Basically, percentage of stenosis, if it's tight or narrow. However, what we were always missing is the physiology and the hemodynamic significance of that. The only possible ways to do that is in the cardiologist realm with stress echo, nuclear medicine stress tests, and
Some form
conventional
of stress test.
angiography.
Stress
Exactly. And then, so here we saw that tight stenosis in the right coronary artery. And the question is it artifactually tight because of the calcification, or is it really stenosis? With what the FFRCT calculates the flow before and after the stenosis. And what we hear, any change less than 0.8 is hemodynamically significant. So bottom line here, if it's red, it's bad, and if it's blue, it's good. And you can see the area of stenosis in the mid right RCA that we thought was
Corresponding to here.
corresponding to here. We see the score is 0.93. So actually the flow is really good.
Right. So we've essentially, through a bunch of physics and artificial intelligence and technology, we figured out what the flow is beyond the narrowing, and we would call this not significant. So
Yeah.
it's, in a sense, we've done a stress test on that artery segment without ever having to do a cath.
Correct. Yes. So we prevented traditionally, when I would call you, you know, and traditionally in the old model, I would say, hey, Dr. Mishkel, this is probably a moderate stenosis greater than 50%, you know, probably around that. I would actually grade it severe and downgrade it to moderate just to account for a calcium blooming artifact and say, hey, you might want to cath this patient or consider other things. But now with this technology, non-invasive, we're able to prevent further downstream testing.
So on the far right here, we have a different artery, and it's in red.
Yeah, so obviously red is bad. So this artery right here is the left circumflex artery. So let's go to the recons of the left circumflex. So this is how we traditionally did it right here. So obviously, as we go into the left main, you know, and it splits into the left circumflex, and around the mid left circumflex, it's a little bit inhibited by motion artifact, but as you can see here, there's a very tight stenosis here, non-calcified plaque. That's most likely real. My diagnostic confidence is there, but there is a lot of noise, so there is still room for error. Here also we have the dense bright areas of calcium, and I would grade this severe stenosis, but downgrade it to moderate just to account for the
Calcium.
the artifact, you know. So, but then the question is, now we're back to the same dilemma. Is this real or is this not?
What's the flow?
And what's the flow? And if this is this anatomically, it seems significant, but more importantly, is it hemodynamically significant?
So don't keep me in suspense. What's the answer?
So basically, at the area of that tight stenosis, as you can see here, oops, sorry, the mouse is a little, okay, here, as you can see here, distal to the stenosis, the decrease in flow is hemodynamically significant, less than 0.5, as shown in red. So therefore, this patient would probably benefit from
A cardiac catheterization.
cardiac catheterization, exactly.
So this technology, which is from HeartFlow, a company out in California, is this available everywhere? My understanding is that we're the only institution outside of Loyola up in Chicago that has this technology.
Yeah, we're one of the first adopters in the state of Illinois. There's only a few institutions, actually nationwide, that are starting to adopt, but locally here, we're one of the first institutions to offer it.
Well, I know, Vince, you have a lot more to show us, but we're out of time. I want to thank you for taking the time of setting up these studies for us, and then also on the behalf of all the cardiologists, I want to thank you for all the time you've invested in working with us and collaborating and making our program all the better for our patients. Thanks a lot, Vince.
All right, thank you.
Remember my calcium scan? Well, just about an hour after I left the hospital, I got the text message that nobody wants to get. Call your cardiologist immediately.
Hey, Mark. Mark, how are you? Well, I'm gonna get right to the point. You have a very high calcium score. Yes. Do you have a family history? I'll be a son of a gun. It's very high. Now, it is not, I mean, it just indicates that you have hardening of the arteries. It doesn't tell you, whether you have blockages, and it doesn't tell you whether you have blockages that are impeding blood flow. Now, the fact that you have no symptoms and you're as active as you are, to me would indicate that the chance that you have a serious narrowing is not that high, but be that as it may, you're in the 99th percentile for calcium. Yeah. So I think that the next step is you come in to see me, and I have I've made an opening on Thursday, and at a minimum we're going to do a stress test.
Okay, now I had one of those several years ago.
Yes, I know.
Okay.
So it'd be interesting to see how well you do, and then I think we need to make a decision about whether we just live with that stress test result or we go another step further.
Mm-hmm. And we would know. Would we know like immediately after the stress test?
Yeah, I mean, yes, I'd tell you right away what I thought of it.
Yeah. Okay. Well, Thursday it does happen to be a pretty good day for me.
So I have Danielle here. Danielle, what time is the?
12:30 for the stress echo, 2:30 for his appointment.
Well, Dr. Mishkaloka, here I am with a calcium score of over 2,800. That puts me in the top 1% of men my age. You said, okay, let's fast on this. Let's get that stress test done, and then come see me the same afternoon, which I did.
Right.
So what's your conclusion from all that?
Well, I'm not going to keep you in suspense. The stress test was very good, so I think that I heaved a sigh of relief. I hope you will too. The first thing to stress is that yes, it's a very high number that you have, and yes, it's concerning, and yes, it raises the possibility of events in the future, but it's just a number, and that we have to treat the whole person and take everything into account, including your current symptomatic status, family history, smoking, other risk factors, and so on. So in your case, of all the tests that we could have done, including new CT, FFR, we decided let's do a stress test and echo because you're so fit, and this was such a surprise that I thought that would be the best place to start. Now maybe if you told me, hey listen doc, when I have exercise I get short of breath or I have a little bit of chest pain, we'd have gone right to a heart catheterization. But I know that you play squash or racquetball 2 or 3 times a week. God knows you ride by my house often enough. I sometimes feel like you're stalking me. But anyhow,
Throwing eggs.
Right, whatever. Toilet paper. So we started with an echo. So this is your baseline echo. And in this case what we're doing is we're taking your heart and we're cutting it in half down the long axis, right? Cleaving it in half. So here's your left atrium. That's where the oxygenated blood from the lungs comes. Here's your mitral valve. Here's your left ventricle that does the squeezing. And the oxygenated blood now exits through the aortic valve into the aorta. And what we can also do with this echo is we can put color on it, which shows us whether the blood is moving in the right direction. So here we see that mitral valve. It doesn't show up quite as bright, but we can see that there's no abnormal color here in the left atrium. And there's a little bit, to the discerning eye, a little bit of a blue, right here with the arrow, a little bit of blue flash back there. Your aortic valve just leaks a trivial amount, but everybody does. So this is basically, you have normal valve function. So we get that.
And if I had a lot of calcium in my valves,
that
that might show up.
Yes, and you might have abnormal valve function there. And so we take different cuts of the heart. So now, instead of taking your heart and crossing and cutting it, cleaving it down the middle, we cut it in half. So this is your heart in cross section, like a donut.
Mm-hmm.
And then this thing here, that was the mitral valve that you saw opening before, cut in cross section. So it opens like a fish mouth here. And we see that all segments of your left ventricle thicken or contract normally. So the next step was we put you on a treadmill, and then when you were on the treadmill, we gave you contrast, and then we had you hop off the treadmill, and we imaged you. So here are the baseline resting images of your heart in different sections, and now you see this contrast. And so here's different views of the heart, and you see at rest all segments of your heart thicken or contract normally. So then you did your exercise, and the next display is this. At peak exercise, what do you notice? You notice that your heart is beating away to beat the band. And every area of the heart at exercise contracts normally. Not only does every area of your heart contract normally, but you see there's virtually no contrast or blood left in the heart when you exercise. Your heart generates so much power that it empties normally. And then we can put these pictures up side by side. So here's rest, here's exertion in the same view. This is that short axis view, rest, and with exertion. So at rest, you see there's contrast or blood, and with exertion, all that blood gets squeezed out, and all areas of the heart contract normally. So here in the cross section, we see normal function, and at rest, everything gets squeezed out. So the basic conclusion from your stress echo was all segments of your heart move normally under maximal stress, and the power of your heart is normal because its size gets smaller and all the blood empties. How do I know it was maximal stress? Well, you did over 13 and a half minutes. I couldn't do that. You're about 5 years older than I am, maybe even a little older.
Oh, don't remind me.
Yeah, well, and you got 105% of your predicted maximum. I mean, it was your heart rate went way up. We got a maximal performance out of you, and you had no chest pain, and you had no changes on the electrocardiogram. So putting it all together now, I'd say, yes, you have coronary artery disease, you have plaque buildup, you have calcium, you have hardening of the arteries, if you will, but it's likely, not for sure, but it's likely that none of that plaque is narrowing arteries. And so the trick moving forward is to build a regimen for you where the plaque doesn't get worse or become inflamed and cause heart attacks. And we can talk about how that works too.
Dr. Mishkel, thank you. And to Dr. Zada, too, and thanks for working together. Show us how that collaboration works.
I look to collaborating with you for many years.
Okay. And thank you for watching CARDIA. You know, I hope you enjoyed seeing how these two branches of medicine work together, and also how quick and easy a CT scan can be. And even if you're feeling really good, it might be a good idea to try one. With another CARDIA, Hearts and Sciences, I'm Mark McDonald with Dr. Mishkel. Thanks for watching.